Oh wait, it helps if I hit start webinar too. Here we go. There we go. They start rolling in. Well, as people just start slowly rolling in, I don't want to get started with the entire introduction before we've got more folks. But we already have some hellos to Dr. Smith coming into the chat, so that's wonderful. A few patients, I'm sure, wanted to see you this evening. That's wonderful. Dr. Smith is a great friend of the coalition. We were just chatting. She took a part as a presenter in our first annual gynecologic seminar. We are hosting our third this year, which I'll shed a little bit of light on later on for folks. So that's very exciting. And we're glad to welcome her back tonight. This is a great evening that we've got lined up, and we do have 2 ASL interpreters to join us this evening. So we are kind of playing with the recording and also having everyone on the screen as we need them for the night. So we definitely thank you for taking part and ask you to bear with us. If there's any sort of tech troubles, please put them in the chat, and I'm happy to help out, as is my colleague, Allie Dennison. All right, so it's 7:02. I do want to get started. Good evening and welcome to the Breast Cancer Coalition's evening educational webinar. I'm Christina Thompson, Associate Director for the Coalition. Just a reminder, an email from Zoom went out around 6 p.m. tonight, which included your link to get into the webinar, as well as a link to access Dr. Smith's slides. Allie, just in case someone didn't get that, could you put the link in the chat for them? This is just a way that if you wanted to have the slides while you're watching the presentation, you can do that, print them off on your own if you want. So before we get started, I'd like to invite each of you to register for the Pink and Teal Challenge. This 5K run and 2K walk is happening Saturday, May 13th, starting at 9:30 a.m. and is at Monroe Community College this year. You can register on our website, www.bccr.org. It's a wonderful experience for the entire family. Deanna Dewberry will MC the event, and it includes a vendor village and several food trucks. The funds raised at this and every event put on by the Breast Cancer Coalition stay right here in our region of New York State and help put on programs just like tonight's webinar. As some of you may know, the Breast Cancer Coalition began in 1998 and has grown from serving those in Monroe County to now reaching 27 counties in central and western New York. In 2014, we expanded to serve those with gynecologic cancers and refer to ourselves more often as the Coalition. In September, we will hold the 3rd annual Gynecologic Cancer Seminar, Pathways to Education, Connection, and Survivorship. This half-day event is extended to our larger community. Please reserve Friday, September 22nd on your calendar from 1 to 5 p.m. The Coalition is excited to announce focus groups open to those with gynecologic cancers beginning in June. We would like to know, what did you need when you were diagnosed? What did you find helpful? What was missing in the community, at the Coalition? What did you need during your treatment for gynecologic cancer? And what do you seek during survivorship? If you'd like to take part in these focus groups, I encourage you to enter your email address in the chat for more information or to sign up. These groups will be held virtually and are open to anyone who's experienced a gynecologic cancer diagnosis. If you're more comfortable, you can just privately email me at christina@bccr.org. So let's begin. Thank you to those who submitted questions in advance. There will be a facilitated Q&A following the presentation. Place your questions in the chat. It will be answered as time allows. At any point you leave the webinar this evening, a short survey is going to pop up. We value your feedback, and our program staff uses all comments to improve the offerings from the coalition, so please complete the survey. Here's a brief introduction to Ashley Smith. She's an associate professor in the Department of Obstetrics and Gynecology at the University of Rochester and brings a unique patient-centered focus as a doctor of osteopathic medicine. Tonight, Dr. Smith is joining us from her office on Lattimore Road following a full day. As a gynecology oncologist with URMC, she will discuss the ABCs of GYN cancers, stages and treatments of gynecologic cancer. We're aware that gynecologic cancer are those that start in the female reproductive organs and are familiar with some of the more common types like cervical, ovarian, uterine, maybe even vaginal and vulvar cancers. Tonight, we will learn more about risk factors associated with gynecologic cancers, including signs and symptoms, how they're treated, and what's on the horizon regarding these malignancies. Welcome, Dr. Smith.
Thank you. So is it okay, Christine, if I go ahead and share my screen?
Please do. I'm going to mute and hide myself.
Okay. So let's see, we practiced this earlier, so let's make sure that this is all going to work like it's supposed to. Okay, perfect. So thank you so much for joining tonight. I can see the number of people here. I can't see who is here, but those of you who are here and know me understand that I am very passionate about this. This kind of talk is right up my alley because I think any opportunity we can take as physicians to educate our patients and the community. I also know I've seen a couple highs from some of my healthcare colleagues, so I appreciate them joining in as well. I'm just always happy to take the opportunity to teach women about their bodies and to understand these diseases. It's so interesting to me that, speaking of gynecologic cancers is sometimes somewhat taboo and not something that a lot of information is often shared about. But one of the things we do see are some common myths and misconceptions that get perpetuated kind of throughout the community. And so not only are we going to take the time this evening to go ahead and talk about some of the basics and learn about the 5 most common types of gynecologic malignancies, but we're also going to play a little game and dispel some of these myths. So with that information at hand, let's get started. I think it's interesting to present how common this is, in fact. And basically every 6 minutes, there is a woman that is diagnosed with a gynecologic malignancy. This is not to leave out breast cancer and the importance that the association with breast cancer has, certainly impacting females more than males. But as a GYN oncologist, I focus on these 5 types of malignancies listed on the screen. And so that's what we're going to focus on tonight. Primarily the basics of ovarian and fallopian tube cancer, also an entity called primary peritoneal cancer. Because these often present with the same symptoms and they're managed the same way, we just kind of lump these 3 types of cancers into one group and talk about them all at the same time. We'll then talk about uterine and endometrial cancer. We use those words interchangeably: cervical cancer, vulvar cancer, and vaginal cancer. I won't spend time this evening speaking about gestational trophoblastic disease. This is a rare type of malignancy that we treat. It's a placental pregnancy-related tumor. So we're not going to spend time talking about that. The importance of this and why I'm happy to be able to present this information and do this talk with all of you is that there have been studies that now show that women who are treated by a care team that is actually led by someone like myself or my colleagues, so led by GYN oncologists, they actually do experience better outcomes. We have the luxury, different than medical oncologists, to be able to focus on these specific types of cancers. So it affords us the opportunity to be really well versed and really up in our game on these 5 particular types of cancers. Cervical cancer is the only gynecologic cancer that actually has a validated screening test. So we'll talk some more about cervical cancer. We'll talk some more about pap smears, but I think it's important in terms of we often associate malignancies and screening tests, colon cancers, colonoscopies, breast cancers, mammograms. And so for the types of cancers we have listed here, cervical cancer really is the only gynecologic cancer that there is actually a validated screening test for. So the Foundation for Women's Cancer has really kind of put out here this whole concept that we should be working with and teaching physicians and patients and women of the community, learn, listen, and act. So learn the symptoms, listen to your body, and act by seeking care from a GYN oncologist if you suspect or you have already been diagnosed with a GYN cancer. And I linked to their website here for more information. There's a plethora of information listed here, but I think just kind of parroting them and modeling them, I designed this talk kind of around these three concepts. So learn, listen, and act is going to be what we're talking about tonight. It all starts with knowing your anatomy. And it is mind-blowing to me still at this point in my career that people really don't understand their anatomy. And so when we're talking about gynecologic organs or gynecologic structures or areas that disease can occur, we talk about the uterus, the endometrium, the ovaries, the fallopian tubes, the cervix, the vagina, and the vulva. So the uterus is the organ that we all know where we carry babies. The lining of the uterus is what becomes, for the most part, most commonly, the type of endometrial cancer that we see most often. There are types of uterine or endometrial cancers that develop in the wall of the uterus, although not the most common type. But the lining of the uterus, the endometrium, is what sheds off every month when women who are premenopausal or perimenopausal are still having menstruation. The ovaries are where your hormones come from. People will often make comments about, having their ovaries removed or having their uterus removed and then losing their hormones. And so just having a basic understanding that the ovaries are actually the female reproductive organs that make estrogen and make progesterone. So that's important for women because those hormones in particular are very protective for our heart and for our bones. The fallopian tubes obviously attach to the uterus, and they're kind of the transit or the pathway, if you will, for eggs to travel from the ovaries and then into the uterus. The cervix is the very bottom portion of the uterus, almost like the neck. If you think of the uterus as kind of an upside down pear, the bottom portion, or where a pap smear is completed, is called the cervix. The vagina is actually the inside tubular muscular canal that actually connects the internal GYN organs to the external GYN organs. And then lastly is the vulva, which is the skin or the tissue on the outside of the perineum. And so I put up the bottom picture to primarily show and demonstrate that there are basically three anatomic holes that women need to be familiar with. There is the urethral opening, which is just below the clitoris, which is where you would pee or urinate from. There's the opening of the vagina, which is where you would insert a tampon during menstruation. And there's obviously the anus, the very bottom portion. So I think it's important when we're talking about these structures to kind of understand, there's a lot of misconception when people come into the office about what actually may be going on where. So this is just a basic review of anatomy. When we are talking about cancer and we are talking about malignancy, the two terms you hear us use often are stage and grade. And so just basically to break it down, they mean two totally different things. Stage is where, when you've been diagnosed with a cancer, what is involved? Where is that cancer located? The stage and the grade in combination help to determine and guide decisions about treatment. Stage implies, is the cancer contained? Did the cancer spread outside of the site of origin? Whereas grade is basically how ugly the cancer looks under the microscope. If any of my patients are on tonight, they've heard me say this in the office multiple times. Obviously all cancer looks ugly under the microscope, but there is a scope of ugly. And so for us, for gynecologic malignancies, the grade we usually assign is grade 1, grade 2, and grade 3. Grade 1 being kind of on the less severe or the less aggressive end of the spectrum, grade 3 being the most. Also for our particular types of cancers that we talk about, we reference something called the FIGO staging system, which is a little bit different than some of the other cancers that use what's called the TNM staging system. So let's dive right into talking about ovarian and fallopian tube cancer. And I just basically started and thought we'd work from the top and work our way down and out, if you will. So ovarian and fallopian tube cancer is, it ranks 5th in cancer deaths among women in the United States, and it is the 5th most common cancer for women. It is the 2nd most common gynecologic malignancy. Endometrial cancer is the most common, but it is the most common cause of gynecologic cancer death. Approximately 22,000 women are diagnosed with ovarian cancer every year in the United States, and approximately 14,000 women die from ovarian cancer each year. Most of those numbers play into the fact that only 15% of ovarian cancers are diagnosed at stage 1. So unfortunately, when we're talking about ovarian fallopian tube, and again, I mentioned earlier primary peritoneal cancer, sadly, most of them are diagnosed at advanced stages. And this lends back to one of the first slides that we were talking about, that there just is not a validated screening test for ovarian fallopian tube or primary peritoneal malignancies. So here's the start of our myth and fact part of the presentation. So a pap smear will detect ovarian cancer. Fact, untrue. Pap smears do not detect ovarian cancer. So often women will come in the office and they'll say, but how did I get this? My pap smear 3 months ago was normal. The pap smear is only to detect cervical cancer. Rarely we will get lucky and we will pick up a uterine cancer on a pap smear, but that's not the purpose of the pap smear. So it is a big misconception that pap smears detect all GYN malignancies. They absolutely do not. When we talk about types of ovarian cancer, this is just to kind of link out, and for anybody that may be on here who is, diagnosed with ovarian cancer, just the common types that we see. It's really based on location. So where did the actual cancer in the ovary originate from? The most common type is what we call an epithelial ovarian cancer. That type of cancer forms on the surface of the ovaries and the fallopian tubes. Most commonly, these are classified as high-grade serous, low-grade serous, endometrioid, clear cell, and mucinous subtypes of ovarian cancer. About 5% of ovarian cancers are something that we call germ cell ovarian cancers. They actually start in, they start in the cells that form the eggs, the germ cells of the ovary. Most commonly, those tend to be found in adolescents or younger women, and they often only affect one ovary, whereas epithelial ovarian malignancies can affect both. The last subtype is something we call stromal cell ovarian cancers. They start in the cells in the ovary that are actually responsible for producing female hormones. So basically, the stromal cells are thought of as the cells that actually hold the ovarian tissue together. This presentation would be remiss if we didn't talk about some genetic links and some genetic conditions that develop or put patients at risk for developing these types of malignancies. So there is a syndrome, a familial breast and ovarian cancer syndrome, that now, fortunately, we're able to screen for and do genetic testing for. It is an inherited condition. It is only responsible for about 15 to 20% of all ovarian cancers and about 5 to 10% of all breast cancers. So it is not common, but usually easily detected based on family history, right? So when you come in and we're asking you questions about, do you have breast cancer in your family? Do you have ovary cancer in your family? We're trying to get at this particular entity right here. Different than a couple years ago, where we would only do genetic testing for patients with ovarian or fallopian tube cancer based on family history. We now test all ovarian cancer patients. All will have expanded profile genetic testing. So previously, we only tested for BRCA1 and BRCA2. They still do remain the most common mutations that we find, but now with expanded panel genetic testing, we can go ahead and test for a much broader range. Just as a kind of sidebar for genetic testing that I feel like we don't talk about often enough would be that once you have genetic testing completed, stuff is changing all the time. We're finding new genes, we're finding mutations. So always good to tuck in the back of your mind that your genetic testing should be updated about every 10 years. At this point is what the recommendation is. just to keep current and make sure that you have testing for the most recent gene panels that are out there. Importantly, the last bullet on this slide is because the presence of specific genetic mutations may actually impact now our treatment decisions and our post-treatment care. So for example, we have a class of medications called PARP inhibitors, or I've mentioned DNA mismatch repair deficiency, which links to PARP inhibitors. So we now have specific ways that we can target people who have these genetic mutations or also who have these mutations in their actual tumor. And so we're starting to develop and we're starting to get to the nuances of patient-centered medicine, of individualized medicine, where we can start to target some genes and some abnormalities specific to patients and specific to their tumors. So we are coming a long way. Myself and my GYN oncology colleagues obviously are very excited about that. So certainly more to come in the future. Again, I have to put this up here based on the numbers you see in the first two bullet points. People will say, I have no family history of GYN cancer, so I probably won't get it. The numbers of inherited gynecologic malignancies are small. We'll talk when we get to endometrial cancer about Lynch syndrome, where the numbers are a little bit different. But in fact, only a small percentage of these cancers are genetic. So don't be fooled and don't fall into the trap thinking, oh, no one in my family has it. I didn't think I could ever get it. You certainly can. And so just be mindful of that. Here are listed risk factors for ovarian cancer. Again, I use ovarian cancer, but fallopian tube, primary peritoneal, all again in the same broad category. Your risk will increase with age, especially around the time of menopause. The caveat to that is family history of ovarian cancer and any type of those genetic mutations. Ovarian cancer can show up a little earlier. So yes, we think for most of the population, the risk increases with age, but not specifically true for patients who have a genetic mutation. Again, we talked about family history of any one of those cancers. A personal history of premenopausal breast cancer can put you at risk for ovarian cancer. Infertility and not bearing children. Pregnancy and the use of birth control pills actually decreases the risk. This kind of plays off of the thought of if you believe that most ovarian cancer actually originates from the fact that the ovaries are ovulating constantly. And when you use birth control pills or pregnancy, that ovulation aspect of the ovaries remains dormant. One of the theories of development of ovarian cancer is less mistakes can happen in the repair of the DNA if the ovaries are not ovulating. So that's where that theory comes into play. Again, we'll mention this a little bit down the road, especially with endometrial cancer. Lynch syndrome is another genetic condition that links colon cancer, uterine cancer, and ovarian cancer. So we're asking all of those questions at your office visit. A male family member with breast cancer, that most commonly clues us into some type of genetic mutation, most specifically a BRCA mutation. And then patients who are of Jewish heritage have an increased risk of ovarian cancer. That again goes back to they also have a higher incidence of BRCA mutation. The symptoms of ovarian cancer are unfortunately vague and robust and things that women experience not infrequently. And so this, with the fact that we don't have good screening tests for ovarian cancer, all plays back into why ovarian cancers tend to be diagnosed at a later stage than an earlier stage. So think about it: abdominal bloating, feeling full while eating, pelvic pressure, abdominal pain, urinary urgency and frequency, changes in your bowel habits, abnormal bleeding and discharge, back pain, unexpected weight loss or weight gain. You know, the most common thing that we see, which I try to caution people just logically doesn't make sense, is that you don't gain weight only in your belly, right? I mean, we all pack on a little extra weight here and there, but it doesn't really make sense to say, I'm eating less, I feel full very quickly, but my pants are really tight around my abdomen. That can often be from a pelvic mass, that can often be from the fluid collection called ascites that can accumulate with ovarian and fallopian tube cancer. So please just be mindful of that. If you hear someone say that it should, hopefully this will send up a flag for you that that doesn't make sense. To talk briefly about diagnosis and management, obviously with all of these, it starts with coming in and having a pelvic exam, a physical exam. There are laboratory tests that we can complete for someone who has the diagnosis of ovarian cancer or who has a pelvic mass and we are suspicious of an ovarian cancer. I'm very quick to correct people that CA-125 and HE4 are not specific tumor markers for ovarian cancer. So they are the best we have at this point. And again, we are making progress. There's lots of stuff on the horizon about blood testing for tumor circulating DNA, lots more to come with that in the future. But where we are right now is we use these two lab tests to help us diagnose a potential ovarian cancer, but also to follow our patients during treatment. So as we're administering chemotherapy, we like to see, in fact, these numbers come down to normal. Important to remember, again, as I pointed out before, they're not specific to the diagnosis. So only 50% of women with an early stage ovarian cancer will have an elevated CA-125. And it is elevated in 80% of women who have advanced stage cancer. So again, that lends itself back to what we talked about earlier. Difficult to diagnose ovarian cancer at an early age because of all the symptoms, no good screening tests, non-specific lab tests, but again, it's the best we have. I left out the other markers for germ cell tumors and stromal tumors just to keep it more streamlined and simple, but there are other specific tests that we can use to track and trend those types of malignancies. The imaging that you'll hear us complete most frequently is a CT scan, oftentimes of your chest, your abdomen, and your pelvis. Sometimes ultrasounds, MRIs, sometimes PET CT scans are used for findings that may be indeterminate on a CT scan or a pelvic ultrasound. Patients frequently ask for PET CT scans, and I'll be honest, they're not usually covered by insurance companies as frontline imaging for gynecologic malignancies, unless it is vaginal cancer or cervical cancer. So oftentimes, we don't need the PET scan to show us anything in addition to what a CT scan can already show us, which is oftentimes why they're declined by insurance companies. So in talking of treatment, again, this is just a brief overview. These types of cancers are managed a little bit differently. We manage them based on symptoms. We manage them based on imaging findings. So where is the tumor? Where is it located? What is the distribution? And what symptoms our patients are having is basically how we plan the combination of surgery and or chemotherapy. So we use them in varying orders to treat patients based on how they present to us. The goal of surgery for an ovarian or fallopian tube cancer is when I take my patients to the operating room, I know the patients that have the best outcome are the patients that we leave no visible tumor behind at the time of their completion surgery. And so oftentimes what we will do is use chemotherapy up front to try to melt away some of that tumor to make our surgery more successful. The surgical terms, I just wanted to list there for you in case I throw them out sometimes. I wanted to be sure everybody knew. Obviously, hysterectomy is just when the uterus is removed. Salpingo-oophorectomy is when the ovaries and fallopian tubes are removed. A staging surgery means that we are sampling tissues. We are removing lymph nodes. We are taking biopsies. There is this ambiguous organ that you'll hear us talk about called the omentum, which is basically just a fatty apron that hangs off of the transverse colon in our abdomen. But important because as the free fluid in our belly circulates around, if there are cancer cells in that free fluid, the omentum can essentially act like a vacuum cleaner and suck them up. So what we'll start to see is some thickening of that area. We'll see it on imaging and we'll see it at the time of surgery. The word for that in terms of this type of cancer we call as an omental cake. So those are basically kind of just a quick overview of ovarian, fallopian tube, and primary peritoneal cancer. I think importantly, endometrial cancer and uterine cancer is something we need to spend a good bit of time speaking about. We are seeing the rates of this type of cancer rising. Most specifically, we think this is related to the increasing rates of obesity and the increasing rates of diabetes. So we'll talk about that a little bit more. But as you can see from the bottom picture on the slide here, now we are talking about cancers inside of the uterus, whether or not that's in the lining of the uterus or whether or not that's in the wall of the uterus. These are the types of cancers we're talking about. And again, we use uterine cancer and endometrial cancer interchangeably. So in my conversation, I'll probably swing back and forth between those two terms. I had mentioned that in developing countries, this is the most common gynecologic cancer. It's the second most common cancer in developing countries because in some of these developing countries, they don't have access to pap smears like we do. And so cervical cancer still tends to be the leading malignancy in developing countries. It is the fourth most common cancer among women in the US, and about 1 to 2% of women will be diagnosed with endometrial or uterine cancer. The peak incidence is around 60 to 70, although today, interestingly enough, I was just reading an article this morning that is the rates of endometrial cancer in young Hispanic women between the ages of 35 and 39 have increased dramatically, almost 2%, which is a significant increase. And so the article I was reading kind of was in the Hispanic population also, there are higher rates of obesity and diabetes. And so probably that's what's coming into play here. There are types of uterine cancers that we classify into type 1 and type 2. Type 1 are the most common types of cancers we see. They're about 80%. Those are the kind that are slow growing. They usually behave very well if they're diagnosed early on. They are estrogen induced. So the reason why most women develop uterine or endometrial cancer, and the reason why it happens in the ages of 60 to 70 is because that's when women are menopausal. They lose that balance in their ovaries of estrogen and progesterone. And so without that balance working together, the lining of the inside of the uterus will thicken. The reason obesity plays into the diagnosis of endometrial cancer is all of the fat cells in our body make estrogen. They make a peripheral source of estrogen. So when you are obese or you are overweight, your uterine lining is seeing an excessive amount of estrogen and it's not getting enough progesterone, either because it just can't keep up or because you're menopausal. And that leads most commonly to the development of most types of endometrial or uterine cancers. The least common types are the type 2 cancers. The two most specific common ones of those are the papillary serous and the clear cell. Those are not related to excess estrogen, at least what we believe to this point in time. They are the rarer types. We don't see them as often, but they also tend to be more aggressive than the type 1 types of endometrial cancers. So this is a big one. If you don't remember anything that I tell you today, please remember this. My period came back. When people say that to me, I can't tell you what it does to me inside. Your period will not come back. It should never come back. Menopause is defined as the absence of menstruation for 1 year. So ladies, write it on your calendar. You know, physicians, counsel your patients. Write it on a calendar. Once your period goes away for a year and it is gone for a year, it does not come back. And so any source of bleeding at that point in time must be evaluated. Risk factors, we started talking about again alone. I don't think too often this happens anymore, taking estrogen alone without progesterone. We're much more savvy about hormone replacement therapy than we used to be. Again, not to beat this over the head, but obesity and not maintaining a healthy weight is the most significant risk factor. Late menopause, diabetes as it relates to obesity, not bearing children, we think that's related to a theory on anovulation. So again, if you are unable to get pregnant because your ovaries aren't functioning well, then they're consistently not making that balance of estrogen and progesterone, which leads to the inside lining of the uterus being unhappy, which then puts you at risk for developing a uterine cancer. Family history, we'll talk about a little bit more. I've mentioned already something called Lynch syndrome. And then the use of tamoxifen. So tamoxifen is a medication that is often used for ER receptor positive breast cancers because it significantly decreases the risk of recurrence for breast cancer. It works as an anti-estrogen or an estrogen blocker in the breast. Unfortunately, it works as a pro-estrogen in the uterus. And so it has opposite effects on the breast and the uterus. So that's why it's important to know, and people taking that medication need to be counseled extensively about any abnormal uterine bleeding or postmenopausal bleeding. Again, we've talked about abnormal vaginal bleeding. It can be anything. It can be bright red. It can be brown. It could be just spotting. It could be heavy like a period. In younger women, if you're having irregular cycles, very heavy cycles, and you have risk factors, that should be evaluated. This is, I think, probably what I hear most commonly and what I see most commonly in the office when women come in is that they've presented for evaluation. They're complaining of blood in the toilet bowl. And immediately everybody thinks that people have a urinary tract infection. I am here to tell you that if your urinary tract infection is so bad, it is causing bleeding, you're likely on your way to the hospital for a really severe kidney infection. Urinary tract infections do not cause bleeding enough that you would see it in the toilet bowl and it would be grossly obvious. So please, please, please don't let somebody explain away your bleeding as coming from the urine. Sure, we see it when we sit down to pee because it comes out, the blood from the vagina comes out and hits the toilet bowl. Everybody associates that with, oh, I went to the bathroom, I urinated, and then I had bleeding, but it's not coming from the bladder. So please don't let anybody treat you with consecutive courses of antibiotics for a urinary tract infection that won't go away. Okay, that's not correct. For diagnosis and management, again, back to the basics, pelvic examination, and then some type of tissue sampling from inside of the uterus. We can do this two ways. We can do it with a little straw-like biopsy in the office, or if we're unable to do it in the office or patients are unable to tolerate it, or we want a better sample, we'll take patients to the operating room and do a scraping of the inside lining of the uterus called a DNC. Imaging, most commonly we use here is an ultrasound, because what we're trying to do with the ultrasound is measure the lining or the thickness. There are specific cutoffs for women who are premenopausal or postmenopausal for the thickness of the lining of the uterus. So that's what we're trying to measure here with ultrasound. Anytime that uterine lining is abnormally thickened, a biopsy should be done. A caveat to that, though, is those type 2 cancers of the uterus that I spoke about. Oftentimes they don't thicken the lining. So again, don't let somebody tell you that you had postmenopausal bleeding, you had a normal endometrial stripe or a normally thick lining, but you're still having bleeding. That must be biopsied. Somebody needs to get tissue from the inside of that uterus to make sure that everything is all okay. Surgical staging here is what's considered a standard of care when patients are medically operable. That consists of some form of hysterectomy, whether or not it's a traditional approach abdominally, or whether or not it's a minimally invasive robotic or laparoscopic surgery. We will remove both ovaries and fallopian tubes for most women. We do make exceptions for women who are younger with this diagnosis. And then now, as they do for breast cancer, we can actually do for endometrial cancer something called a sentinel lymph node sampling, which is where when you're asleep in the operating room, we will inject a green dye into the cervix and look for the first draining lymph node. This helps us avoid a full lymph node dissection in the groin, which can result in significant leg swelling. For people who are not candidates for surgery, we can talk about hormone therapy and we can talk about radiation therapy, and then in worst case scenarios, chemotherapy. Most of the time, surgery alone for type 1 cancers is sufficient, not true for type 2 cancers. But the most common modality that we use is external beam or is radiation therapy. That can happen in two forms, external beam or some internal vaginal cuff brachytherapy. And then a cool thing that we've kind of come up with about endometrial cancer is we can actually test the cancer cells from the uterus for something called mismatch repair proteins to try to clue us in to whether or not there is Lynch syndrome present. So again, as I spoke about before, the endometrial cancer risk in patients with Lynch syndrome is about 40 to 60%. The ovarian cancer risk is about 10 to 15%. So not insignificant for those patients, in addition to the risks of other cancers that are associated with Lynch syndrome. Moving on to cervical cancer, this is where the pap smear comes into play. In the US, we have about 14,500 women diagnosed yearly. About 4,300 will die from cervical cancer. Again, the highest incidence of cervical cancer is among Hispanic women, and some people think or attribute this to disparities in healthcare and access to care. And again, not to keep repeating myself, but this is a unique type of cancer because nearly all types of this cancer can be prevented. This is where we talk about a vaccine that can actually eradicate a particular type of cancer. There are two most common types, squamous cell cancer and adenocarcinoma. Again, about 75 and 25% is the breakdown for those. Risk factors, HPV infection is the #1 risk factor, and we'll talk about that on the next slide. Mostly it affects women between the ages of 30 and 50, but younger women are also at risk. And then smoking. If you're ever going to quit smoking, this is why you would quit smoking, because smoking weakens the immune system and can lead to persistent HPV infections, which can subsequently cause a problem for women. HPV is a common sexually transmitted viral infection. It is associated not only with cervical cancer, but we'll talk about it with vulvar and vaginal cancer, as well as penile, anal, mouth, and throat cancers. HPV infection can cause cervical cancer, but most people with HPV do not get cervical cancer. So if you look here, it's present in about 45% of men and about 40% of women, but most of those patients have an immune system that is strong enough to keep that HPV virus dormant and to keep it quiet. Some patients don't, and that leads to the development of cervical cancer. But please be aware there is a vaccine. It is effective. It is very effective. In this country now since 2018 or 2019, I believe, the only one available is Gardasil 9. It used to be Gardasil 4 and Cervarix. The CDC is recommending girls and boys between 11 and 12 should get vaccinated. I know there's a lot of opinions about vaccines, et cetera. But if anybody is interested in this one, you can find robust data out of Australia on the eradication of cervical cancer in that country as it relates to the HPV vaccine. It's quite fascinating, actually. And I'm saddened that we've not done a better job here in this country, but I am motivated to keep plugging along and vaccinating people because I strongly believe in it. The symptoms of cervical cancer relate to vaginal discharge, abnormal vaginal bleeding, vaginal odor, pain, and bleeding with intercourse is probably the most common thing women presenting with cervical cancer will complain of. Again, another myth that we have to dispel is that once I have had a hysterectomy, I do not need a pap smear anymore. That may be true, that may not be true. It just depends on why you had the hysterectomy and the results of your previous pap smears and HPV tests. And I will tell you a little cheater physician thing. We don't have to know any of this anymore. There's actually an app for our phones, for the computer, that we can plug all of these results right into. And there's a whole college that provides guidelines exactly for us to manage and treat patients. So it was hard. The pap smear guidelines changed quite frequently, but now there is an app. So again, just because you've had a hysterectomy does not mean you do not need a pap smear. It also does not mean you should not present for your annual well woman care, which I just stole a myth from a slide coming up, but remember that. So the physical exam, again, is very important. Pap smears are screening tests. If a lesion is seen when your doctor does a speculum exam, they absolutely must take a biopsy, whether or not that's in the office, whether or not that's in the operating room. Sometimes pap smears lead to something called colposcopy, which is where we use a microscope and some acetic acid or some vinegar to look at abnormal staining patterns on the cervix. And if we see that, then we go ahead and biopsy it. Here, the imaging that we complete for the diagnosis here is one of those exceptions to PET CT scanning, where it is very helpful. It can now actually be used in the staging for cervical cancer. And so insurance companies will approve PET CT scans for cervical cancer. Treatment for cervical cancer is unusual and really depends on the stage. It depends on how big the actual cancer in the cervix is as to whether or not we can offer surgical removal or whether or not we have to offer radiation and chemotherapy. That's because if you think about the anatomy that we talked about, there's only so much room to be able to surgically remove the cervix because the bladder sits directly on top of it, the rectum sits directly below it, and the ureter sits directly lateral to it. So sometimes for bigger cervical tumors, we actually can't offer surgery and we have to offer chemotherapy and radiation. Vaginal cancer is one of the rarer cancers actually that we see. In order for something to be diagnosed as a vaginal cancer, the vulva, the outside skin of the tissue, has to be completely free of cancer. And the cervix that we just talked about has to be completely free of cancer. The highest incidence of vaginal cancer is among Black women. And about 2/3 of them are caused by HPV. And again, it's a disease of women of older age. So people will often say, I didn't need a pap smear anymore. My doctor told me not to come back. That's actually not true because the older you get, the problems you have can change from location. It can change to the vagina and it can change to the skin on the outside, the vulva or the perineum. The most common types of cancers of the vagina are squamous cell cancers. We do see some adenocarcinomas and some melanomas, and then infrequently we see a subtype called a sarcoma. Again, risk factors for vaginal cancer, very similar to cervical cancer, very similar to vulvar cancer. Persistent HPV infection, smoking, age. We don't see DES exposure so much anymore. As you can see here, it remained in use until about 1971, but the peak years are there. So we're not really seeing too much of that anymore. I feel like it was like kind of phasing out during my training. So I list it here as a possible risk, but it's not so much applicable in 2023. Again, vaginal bleeding, bleeding with intercourse, problems moving your bowels, problems moving your bladder, a watery vaginal discharge, or palpating some type of lump or mass in the vagina. Physical exam, again, sometimes these are detected by pap smears. Most oftentimes a biopsy is indicated. We can sometimes get PET CT scans, but most of the time, just a regular CT scan provides enough information. Sometimes we'll do pelvic MRI to assess invasion, possibly into the bladder, possibly into the rectum. And then these are treated basically with a combination of surgery, radiation, and chemotherapy. The surgery just depends on how big the lesion is and where the lesion is located, because that will dictate what all would have to be removed with a surgery. And we often will forego surgery for patients who have larger advanced stage cancers and treat with chemotherapy and radiation. Vulvar cancer is the last cancer to talk about today, and I think so important, again, because this is the cancer that I feel is missed most often because it happens in elderly women. So the average age is 68, and so usually at this point, women have stopped going to their gynecologist or their family practice doctors have stopped doing pelvic exams and pap smears. And so these cancers often go undiagnosed. The most common types are squamous cell. Again, we do see a good amount of vulvar melanoma from tanning bed use naked. Basal cell carcinoma, there's some Bartholin gland adenocarcinomas, sarcomas, and then there's this entity called Paget's disease, which if left untreated can also turn into a vulvar cancer. Again, you'll see this is linked to the HPV infection like we've talked about before. Smoking comes along with the HPV infection, relating again to immunodeficiencies. So if you have a weakened immune system, some other type of cancer, receiving chemotherapy for another type of cancer, positive HIV status, any sort of rheumatologic conditions, those can again weaken your immune system and weaken the ability for your immune system to keep that HPV quiet and dormant, which then could lead to the development of cancer. The most common symptoms we hear are people complain of itching that will not resolve. And usually by the time people get to me, they have been prescribed all sorts of creams and lotions and potions, etc. I would caution you that if somebody gives you a cream or an ointment or something to use for an area that is itching or that is burning or that maybe looks like a white plaque or is just abnormal, and it doesn't get better within 2 to 3 weeks of use, stop using the cream, go back, ask for a different opinion, ask for a biopsy, ask for a referral. Don't let it sit, because any type of cream or anything that's going to be used at that point should get better within 2 to 3 weeks of time. Diagnosis and management, again, is similar to the other cancers we've talked about. Biopsies are done. Grossly visible lesions have to be biopsied. Imaging, again, can be completed once we have the diagnosis of cancer. And then again, similar to cervical and vaginal cancers, the treatment for these really depends on how big they are and where they are. So can we remove a little bit of the tissue? Do we need to go a little bit deeper? And do we need to sample the lymph nodes in the groin? And then based on the stage, as we talked about earlier, that dictates if we need radiation therapy, chemotherapy, or perhaps a combination of both. Again, I mentioned this earlier, and I'm just going to say it again. Please go to your gynecologist or your family practice doctor at least annually for some type of pelvic exam. You need the skin of the outside of the vulva evaluated and examined at least once a year, and certainly sooner if there are any concerns or complaints. Again, I kind of just put this in here not to go over and not to review it all, just because I mentioned it in all of the last slides. You can look back and reference the things that we do, and for surgery, radiation, chemotherapy. I will talk a little bit about targeted therapy coming up, because that's kind of the forefront of where we're going, not just for GYN oncology, but for most types of malignancies. And I do have to put in a plug for clinical trials. Here at the University of Rochester, we have a robust clinical trials program. And so, we screen our patients to see if they're eligible, because this is where we get our data. This is the forefront of medicine. This is where we are able to come up with all of this new cancer-directed therapy. And so I not every patient is appropriate. You have to meet certain criteria to be eligible. But that is something that we do here, and we're very passionate about, because this is what's going to move us forward. This is how we're going to continue to advance care for women with gynecologic malignancies. As I mentioned a little bit, some advances in GYN, I left out a C, GYN cancer care, molecular profiling, targeted and immunotherapy. We do things now that we weren't able to do before. We test the endometrial cancers or the uterine cancers for mismatch repair. We do all of this genetic testing. We call it germline and somatic genetic testing. Germline means I'm testing your blood to see if you have a genetic mutation. Somatic testing means I'm testing your tumor to see if I have any treatments in my arsenal of treatments that I can use to target your specific type of cancer. So we are making significant advances in this arena. We as GYN oncologists often will borrow from things. One of the most significant developments that people are seeing is the development of immunotherapy, PD-L1 inhibitors that we kind of borrowed from lung cancer, but they work very well for specific types of gynecologic malignancies. So this is just in here to talk a little bit about that and to let you know that progress is being made, which is fantastic. So how can I prevent it or find it early? Number one, and most important, is pay attention to your body. You know what is normal for you better than I do, better than your primary care physician does. You know you. And if something isn't right, don't just explain it away. Go in and get it checked out. A healthy weight, diet and exercise, don't smoke, know your family history, right? And share it with your doctor. If you have concerns or there's a lot of certain types of cancers, don't be afraid to bring that up. Don't just hold those fears inside. It might trigger some genetic testing or further evaluation. Again, my plug for the HPV vaccine, for people who are within that age bracket, I think it's just a really big missed opportunity. And do your annual examinations. At least go in annually to be evaluated. They might say, "Hi, Joe, nice to see you. Why are you here? You don't need anything from me," but that's okay, right? At least they're getting to know you, you're getting to know them. follow the screening guidelines and stay up to date. You know, most recently the colon cancer screening guidelines have changed. They've gone from 50 down to 45 because we're seeing an increased rate of colon cancer in young adults. And so stay up to date because screening and early detection is key. I can't say enough about that. Again, obesity is the #1 preventable risk factor for endometrial cancer. And I think it is something we do a really, really poor job of talking about in this country. I borrowed this slide because, again, I think it puts all of the symptoms for all of the types of cancers in this nice little table. The one thing, when you have time to look at it, I would draw your attention to is that bleeding shows up in every category, right? So again, this goes back to my period came back, or I was moving furniture and I started bleeding, or, you know, I hear all sorts of things. So please just be mindful of that. And if you hear someone talking about that, just be sure to question it or bring it up. You know, pay attention to that. It's really important. Here are some resources that I find super helpful, not only for myself, but for my patients. So I've listed them there and you can check them out as you need to. Feel free to dig around. The internet is good, the internet is bad, but, you know, try to stick to these type of resources to get accurate information and to put your mind at ease. When you're looking at these things, it shouldn't be anxiety provoking. It should be information that's in either a medical professional lingo or in patient-directed lingo, something that you can understand and have your questions answered. And if all else fails, bring them to your doctor. We're happy to answer those questions. I had to put up my colleagues here, who some of you may know. Again, this is just to say that we have a robust program here. We are happy to take care of anybody that needs us. But hopefully with this talk, you won't need us. That's the point, is that we'll be able to direct everybody's attention to early symptoms and early detection, and you won't have to come and see us. That would be ideal. Again, and then this talk again is near and dear to my heart, and I need to take the time to dedicate it to one of the most dear patients of mine who recently passed away. After a 7-year battle with ovarian cancer. I'm not sure if her family is on, but, you know, Jen, we love you. Your spirit was amazing. And to know Jen was to love Jen, and to have the privilege to care for her for 7 years was amazing. So this talk is dedicated to her. Her memorial service is tomorrow. And so my hearts go out to her husband and her daughter during this time. And they know that we love them. And I'm so appreciative to have been able to care for her. So that is all I have. I'm sorry they're vacuuming. I don't know if you can hear it, but this is what happens, I guess, at night at 8 o'clock on a Wednesday night. So I'm sorry. But I guess, Christina, I'll turn it back over to you for questions if we have time.
That was amazing. I want to just make sure that I am, okay, replace spotlight. Is that the right thing? Okay, I'm going to just add. I'm not sure. Thank you, Dr. Smith. I almost was, tearing up at the end because we've recently lost someone at the coalition to GYN cancer, and it's very moving to hear that you think that same way about them.
Oh, I do. So, my patients are my family, and if your doctor doesn't think of you like family, you don't have the right doctor. Let me assure you on that one. And so I just got a text from her husband who is watching. So Matt, we love you, and we're thinking of you tomorrow.
It's amazing. Thank you. Okay, so I want to delve into something because obviously a lot of my experience is more with breast cancer. I am a breast cancer survivor. We are it's a very common thing for a hormone positive breast cancer to be prescribed aromatase inhibitors. And I'm wondering if that is more common in GYN cancers and if they run into the same side effects as estrogen depletion is removed from the body as breast cancer survivors do.
Yeah, we do use them sometimes. We will treat a class of uterine cancers that are often hormone dependent with estrogen blocking agents. And so, yes, we do use them. And unfortunately, we do have the same side effects, that as the breast cancer patients who use them with that estrogen blockade. And so that becomes essential for us to manage these patients with their primary care doctors, who are better than us at managing their risks for osteoporosis and managing their risks for heart disease, making sure, we can all counsel patients about diet and exercise, but making sure your cholesterol is controlled, right? So heart disease is the #1 killer of women. And so once we start talking about blocking all of these hormones, that becomes, very important, right? And it's something that we have to think about, but I will openly admit something that we as GYN oncologists are not the best at. So that's why maintaining a great relationship with your primary care provider to mitigate those side effects of that hormone blockage is super important.
Well, I would also like to just put a plug out there because the Breast Cancer Coalition, we've completed 6.5 years of a very unique program called Surviving and Thriving on Aromatase Inhibitors. Initially, this was for those with a breast cancer diagnosis, and the majority of those have an estrogen, progesterone positive diagnosis and are prescribed this for, years to reduce the risk of recurrence. We've had the magical time of finishing a grant with New York State Department of Health, and it is now a program that has been so well attended and just absolutely loved by the people who participated in it. We are now funding it on our own through different grants and private foundations and things like that, and our own people in our community who donate. And we've opened it up to those with a GYN diagnosis that are prescribed aromatase inhibitors and are experiencing these depletions. And we see things like, joint pain and fogginess, like mind brain fogginess, maybe mood swings, definitely some sexual dysfunction and vaginal wall thinning and things like that, we just encourage you, if you'd like more information about this program, please contact Allie at bccr.org, Christina at bccr.org. We run this program 4 times a year. And basically what we do is we provide tools through education, through occupational therapy, through mindfulness and meditation, as well as nutrition, on just gathering tools on how you can mitigate some of these side effects and stay on the medication, to reduce the risk of recurrence, to treat the disease. But also we're very aware of the side effects and people consider often going off them. So we're happy to open that up to GYN survivors now. And I really just found that a very interesting part of your presentation and things that I've learned from some of your colleagues as well when they've presented for the Breast Cancer Coalition. So that's wonderful. So a question that I had in advance for tonight, are breast cancer survivors at more risk for GYN cancers than other women? Also, how often should breast cancer survivors over 65 years old have GYN exams?
Yep. So are they at risk for other types of GYN cancers depends on the age of diagnosis and depends on the genetic risk factors that we talked about earlier. And yes, absolutely, they should have annual GYN exams. Everybody should. Somebody in the chat mentioned, I was just reading the questions about Medicare, somebody will only pay for it every 2 years. We can find a way to get your exam covered. So you should absolutely present, whether or not it's a small complaint or a minor complaint, or maybe some unusual discharge or something. There are ways to get that covered. So don't let insurance dictate how frequently you are going to get the exam that you deserve. And somebody else asked for a particular postmenopausal women, if there's like a gynecologist who focuses on that. I think with, the nice thing about being here in Rochester is we have an abundance of gynecologic providers. And so I think there are some that do focus primarily on postmenopausal women. So you could certainly seek that out. But also any gynecologist should be able to do the exam.
Mm-hmm. Okay, great questions. This is something I want to bring up. Listening to you're just so empowering to those who have experienced a diagnosis. It's obvious that the people that you treat feel that. But I want to talk about the people who, before they've met a GYN oncologist, are experiencing symptoms that are dismissed by their maybe it's a primary, maybe it's just a gynecologist that they see annually, whoever it is that they're speaking with. So many times people have come to us at the Breast Cancer Coalition with a GYN diagnosis, and they reported the abdominal bloat, the bleeding in between periods, postmenopausal, et cetera, and are dismissed. And then it eventually winds up in an ER situation where it's advanced. You're so empowering, but how do we, as just the general public or somebody experiencing these problems, and I apologize if you hear my dog right now, how do you, what do you recommend? Because it is so disheartening. It makes us feel then that if we are diagnosed at a later stage through an ER, that we did something wrong, and we didn't, you know?
No, it's such a good point. I mean, I appreciate your very kind comments. I am very passionate about what I do. I think I'm very fortunate to be able to do what I do, and I love doing it. But I think not everybody has, I think it's hard as a patient sometimes to find your voice, because you think you're doing the right thing, right? You're going in, you're getting your exam, you're presenting and you're complaining, and you're just not being heard. So in that situation, I just can't advocate for people enough to just keep pushing. That's find a different person. That's, you know, and I mean, we just are coming out of this crazy pandemic where we saw access to healthcare that was just nearly impossible. You couldn't get in to see anybody. Fortunately, that's changing around. But, you know, Christine and I were talking at the beginning of this. Not every doctor is the right doctor for every patient. It is not. Not everybody, I'm a very straight shooter, and some people don't like to hear that, and that's okay. You have to find the doctor that hears you, that advocates for you, and that listens to you. And I do agree with you, getting healthcare in an ER is less than ideal. It's less than ideal. But if that's what it takes, then darn it, that's what you do. You know what I mean? If that's what it takes to get where you need to be, and you feel like you've pushed and you're getting nowhere, then that's what you do. You check with your insurance company and you figure out if they require that you need a prior authorization or you need a referral to come and see a specialist. And if they don't, you call and make your own appointment, right? That's just what you do. It's I think people are getting better at it. I do. I think it has changed a lot. I think people are getting better at it. But you're your own best advocate. And I know it's hard, and I know people don't want to rock the boat, but sometimes you have to.
I definitely agree.
Yeah, I was just going to answer, I think it was Nancy Phillips asked if ovaries stop producing hormones after 65. Nancy, that is a great question, and it's a very hot button topic. So there was a paper that came out a few years ago that said that if we were doing hysterectomies and women were younger than 65, we should leave their ovaries alone. We should not take them out. They've now walked that back in a paper that was written about a year ago, saying that now if somebody is postmenopausal and having a hysterectomy, it's okay to remove the ovaries. The reason for the discussion was because we used to think that when you went through menopause, your ovaries completely shut down. We now know that's not true. We know that they are still making a low-level hormone. What significance that low-level hormone is, we're not really sure. So they're not really, they are producing some hormones. We're not sure the hormones they're producing, if it's truly enough that you would still need them or miss them. So I think that's just an honest conversation with your doctor and why you're having the hysterectomy, and if they feel like they should be removed or not. You're not wrong trying to get additional information. And it's interesting you're asking this question now that the recommendations are changing, which is probably what your gynecologist is alluding to based on that new data that just came out.
So here's another question too, that someone put in the chat. Is someone with both persistent HPV and lichen sclerosis, should I be seeing a GYN oncologist or just a regular GYN? Yeah. I have some interesting questions and observations personally on that as well.
Yeah. I mean, I'm happy to see anybody. It doesn't matter. I feel like it's totally patient preference. Can a GYN manage lichen and persistent HPV? Absolutely. Yes, that is definitely within their scope of practice. Do all of them share the same comfort level with it? No, they certainly don't. And so if you're getting the sense that maybe your provider isn't very comfortable with it or is a little bit unsure, get a second opinion. There's nothing wrong with that.
Great point. Let's see. Should women 65 and way older, in parentheses, have a yearly pelvic exam with a gynecologist who has a focus on postmenopausal women?
Yeah, I alluded to that a little bit earlier. Some people specialize in that. I get it. I think it's interesting. When we're called OB-GYNs and you're like 80 and everybody's like, are you going to your OB? And it's like, no, going to my gynecologist. So I think it's great. I mean, all gynecologists are able to provide that kind of care, but certainly if that makes you feel more comfortable, and there are people, if you're talking about hormone replacement therapy and different issues related to being postmenopausal, you might find more comfort in seeing somebody that specializes in that.
Mm-hmm. Do you have any idea why the Medicare guidelines only pay for GYN exams every 2 years?
No, I don't know why. I don't. It's for the same reasons that they'll sometimes pay for an MRI and sometimes pay for a CAT scan. And, sadly, I don't.
Yeah, I totally get that. So you mentioned in your presentation that tamoxifen can be a risk factor for GYN cancers, and someone asked if anastrozole, an aromatase inhibitor and not the same,
Yeah.
could be considered a risk factor for uterine.
No, it does not have the same effects on the lining as tamoxifen does. So tamoxifen is really the culprit there. And the other ones do not have the same level of proestrogenic effects on the uterus.
Okay. I do have somebody that I'm glad you're here tonight who wrote in that their only symptom of fallopian tube cancer was a lymph node in the neck that was swollen.
Yeah.
I'm glad you're here tonight. That's all I can say. I don't know.
Thank you.
Yeah. What is on the horizon, Dr. Smith? You talked about ovarian cancer not having the same screenings and vaccine possibilities that cervical has seen. What's out there? Is there things that we can be hopeful for? Is there things the Breast Cancer Coalition Advocacy Committee could be talking with our legislative representatives about? Because you are in the right room for that tonight.
There's lots of stuff on the horizon, which is great. And this is why I point out the clinical trials program, because this really is where we're going to get all of this information from. But they're doing some really cool things with your T lymphocytes in your immune system and trying to build T lymphocytes to give back to you that would specialize in targeting, killing your specific type of tumor. So this whole concept of individualized medicine is where we need to go and what we need to do. I say to my patients all the time in the office that, we're not successful in all cases of ovarian and fallopian tube cancer because we throw the same thing at everybody. And we don't know why some people's tumor responds to that and other people's tumor is smart enough to work around it and continue to grow. And so as we continue to find these mutations and we continue to figure this out, that's really, it's so exciting. All of this DNA testing of the blood to see if there's like circulating tumor cells. I mean, it's all coming and it's so exciting. And it's great. We have made such advancements with cervical cancer, vaginal cancer, and vulvar cancer with immunotherapy, with these Keytruda or Pembro. There was just a paper that was published for endometrial cancer with using that too in what we call mismatch repair deficient tumors. So there's so much stuff. It's changing all the time. I didn't put her on the slide, but we are fortunate enough here in our office. We work with a medical oncologist, Dr. Rachel Turner, who does all of our chemotherapy and immunotherapy. And it's amazing to have her here in this office because she teaches us new things all the time. And to have a medical oncologist that only focuses on gynecologic cancer treatment is amazing. She's an excellent resource, someone we refer to all the time. And so we're very lucky to have her. She heads up our part of our clinical trials program and then our immunotherapy and targeted therapy clinics. So she's fantastic.
She's also a part of our research advisory committee, and we spent a long day together on Monday, reviewing proposals. She's a wealth of information. I totally agree with you.
So smart. Yeah, she
can never leave.
No, and she loves her job just as much as I love my job, so
That's
so she's
amazing.
very good at it.
So I sit on the advocacy committee of the Breast Cancer Coalition, where we work on legislation. And something that we're working on right now that has been coming along the line and has had advances over the years, but still not completely an issue, is things like period products and the chemicals that are in period products that we insert into our bodies that have chemicals in them that, through research, have found to increase the risk of cancer. So people like us, survivor advocates, lend our voice and talk to our legislators about these things. We ask that the industry either removes the chemicals and or labels them all on the box so informed consumers can make the decisions about what they want to use and purchase. What are your thoughts on some of these environmental factors leading to gynecologic cancers?
Oh, I think we're just scratching the surface of figuring out that what we are eating, what we are putting on our bodies, what we are putting in our bodies is all going to turn out to be substantial as it relates to the developments of cancers. I mean, people have probably seen in the news, it was ovarian cancer and the use of talc products.
Right.
Now it's endometrial cancer, uterine cancer, and the use of dry shampoos and chemical hair straighteners.
Mm-hmm.
So, I think that, everything within moderation, but I completely agree with you, right? Like, this is something that we've never even thought of, right? We've just been given these feminine hygiene products and asked to use them because that's what we have. And what really is it doing to us? It's a great question. And I do believe we're just scratching the surface of all of that information.
Mm-hmm. I think also it's very hard to imagine. I'm 40, almost 44 years old. It's hard to imagine that I've been living in a country, a very well-off country, where the industry and the government isn't controlling that chemicals would be something I use in my body. But I think that we as survivors who feel a passion once a diagnosis is hitting us in the face, whether we're the one diagnosed or somebody very close to us that we love, and we want to do something about it. So if you have that sort of inclination, to anybody listening tonight, I know we have some of our advocacy committee members here. That's something that you can definitely get involved with. It's an amazing process. It kind of gives you a way to not just let it happen, but to do something about it and prevent it, hopefully in the future. And you can definitely contact me at the Breast Cancer Coalition or just call and talk about that kind of thing. We can answer a lot of questions and put you right to work if that's something you're interested in. So Dr. Smith, I thank you so much. I do have one more question. Somebody wrote in that I had endometrial cancer and I follow up with my onco doctor every 6 months. Should I still be having a pap smear too?
Yeah, that's a great question, Sylvia. The pap smear answer is no. And that changed when I was a fellow. So back in 2013, the surveillance for endometrial cancer was every 3 months you would have a pap smear. But truly, honestly, pap smears are made to detect cervical cancer. And so now we finally have gotten smart and said that we've looked at the data over all these pap smears we were doing for endometrial cancer surveillance, and they weren't picking up any sort of recurrence of endometrial cancer. So yeah, completely a pelvic exam, yes, a pap smear, no.
Okay. So I'm going to ask you a question, it's for me personally and something that I've been dealing with. I have a history of HPV positive. Let's see, pap smears coming back, squamous cell and things like that. I've had treatment for it. Everything's been fine for years and years and years. Then I have breast cancer and I go through all the treatment for that. Now I'm in the point where I'm having irregular pap smears without the presence of HPV. It puts my fight right way up there because of everything that I've been through. But going back to something that you alluded to with the blood biopsies and seeing things like shedding and over treatment, honestly, that we look at, I've been told to just kind of hold my horses and go back to my annual exams, but I'm worried. I'm ready to just like jump into surgery and do all these things. What are your thoughts?
Yeah, I can appreciate both sides of that. So
Mhm.
as the doctor side of that, We have very good data. It's put out by the ASCCP, so that they're the people that dictate all of the screening based on pap smear results. There's very good data about timing and regularity of pap smears and who's at higher risk. And so the likelihood of having a low-grade cervical dysplasia develop into a cervical cancer within a year's time is highly unlikely. That's why that year we feel like is safe. It's okay. I can understand, being a cancer survivor, the patient side of things that says, listen, I don't want to do this anymore. I am done with this. Just take it out. That is all fine and good, as long as you are aware of the fact that depending on what your pap smear was and what the abnormality in the pap smear was, may put you in the category of patients that still needs to have pap smears 20 years after your hysterectomy. And more than likely, that HPV that's causing the abnormality in the cervix could start to cause abnormalities in the vagina. So I think it's fine, and I think there are clear indications for doing hysterectomies in that setting. However, I think we do a really bad job of counseling people that HPV that's now activated and causing grief in the cervix might do the same thing in the vagina. So it might not mean you're done with it. So even though you're done with it in the cervix, if the cervix is gone, there's still the vagina, there's still the vulva.
Thank you. I will hold on surgery following that discussion. Thank you very much. We had Janet who just wrote in that it was a great presentation. And honestly, this was geared toward an earlier staging, just a very general overview of GYN cancers and treatments. And I will say that we absolutely do have a place for that. And that is our common ground group, which is for advanced breast and GYN cancers. That's going to be your stage 3 and on with any sort of GYN cancers. And this is a group of thriving, amazing individuals who are living with their metastatic disease, with their advanced cancer disease. I encourage you to reach out to the Breast Cancer Coalition. And if any of our Common Ground peeps are on the call tonight, I would absolutely ask you to plug that too. We definitely have a place for you with a lot of education. This was geared more towards the earlier stage and just kind of a general overview. So thank you, Janet, very much for writing in with that. Okay, so Amy is here, and I thank you so much for being here. I do want to read her question. She joined late. She did let me know she had something going on earlier today. Endometrial cancer is not discussed much. Why is it? Have the rates of the cancer increased since COVID or the vaccine? Is there a correlation? She's also a younger person in her 40s, has now had a radical hysterectomy because of the diagnosis. What sort of tests or blood work are available to help figure out estrogen levels a person needs? I know she's got a lot of questions here.
Yeah, no, I can start to break some of them down. I'm sorry, Amy, if I missed some of them. Yeah, I have no idea why we don't talk much about endometrial cancer. I really feel like that lends itself to the second issue, that we don't talk much about obesity as it relates to endometrial cancer. And so I'm not really sure why, since it is the most common cancer that we see here, we don't really talk much about it. No data as of yet about COVID vaccines and endometrial cancer rates. I mean, probably is truly, honestly, too soon to tell. So nothing that we know about correlation and causation as it relates to that. I think that's going to be a difficult one to prove, unfortunately, because as society continues, to become heavier and heavier, it's difficult to make these correlations because obesity is such the predominant risk factor for endometrial cancer. There are a lot of commercially available tests, not that we do here, but kind of this whole hormone therapy supplementation thing is really taking off. And you can actually Google it online. Most of it is not paid for by insurance companies. Like I said, they're commercially available companies that will do saliva, that will do blood. They'll test for all of these hormones, and they'll come up with a regimen that is very specific to you, very different than what we in the clinical setting have available to us. I don't know, a lot of times these places will have programs available or stipends available to patients that have cancer. So if you're going to do your research and look into one of those commercial programs, you always want to bring to the forefront that you're a cancer survivor and that you lost your hormones because of this cancer, and see if there's any way they can compensate you from a cost perspective. I just always put that out there for my cancer patients. Pelvic floor therapy is amazing if it works for you, and if it doesn't work for you, it doesn't work for you. And the only way to really know is try, is go get some pelvic floor physical therapy and see if it really works or if it doesn't. There's lots and lots of things that can be causing that dysfunction. And so really having the evaluation to see if somebody can pinpoint and target exactly what's causing your symptoms is helpful.
Also, Amy, as another note, we've definitely at the Breast Cancer Coalition been connected with people that work extensively, physical therapists, pelvic floor health, and I could absolutely get you connected with things like that.
Yeah, and we have resources too, so I can provide them to Christina if needed. Yeah, there's a really good physical therapy program. We didn't talk about it, but also another member of my team here is Dr. Pebble Krantz, who runs the Sexual Health and Wellness. She runs the Center for Sexual Health and Wellness, which she does a lot of talks for the coalition too, I think. I think she's amazing. I think she takes away the stigma of all things related to sexual issues that we don't talk about after women have gone through all of the things we put you through with treatment for these cancers, radiation, surgery, chemotherapy, what that does to you physically, what that does to you emotionally, what that does to you mentally. She's amazing. And so I can't plug her enough to get plugged in with her. If that happens, if you're on and you're listening and that really is a topic for you, she's fantastic, a great resource.
Absolutely.
Yeah.
We cannot speak enough about Pebble Krantz and her entire team. She is a game changer for a lot of people who come into the Breast Cancer Coalition facing a breast or a GYN cancer. And that's the last thing that they're thinking of. But of course, it's going to come up. And there's so many resources. There is no stigma.
Yeah.
If Holly Anderson were here, she'd tell you how much she loves to talk about sex. And it just like it needs to be a part of the conversation with cancer treatment. But I think I've got a last question here from Betty Jean. If a postmenopausal woman had no children and spent years having periods quarterly by taking progesterone medication, are they more at risk for a GYN cancer?
I would have to say yes, Betty Jean, because you're alluding to two things there. Number one, as I pointed out, one of the risk factors is nulliparity or not having children. And that kind of relates to the second part of this question, where if you're needing progesterone medication to have periods, that tells me that your ovaries aren't functioning appropriately. So what that risk becomes now in a postmenopausal setting, we're not really clear on. But I would certainly say that two of those risk factors for the development of endometrial cancer are present in that scenario that you presented. And so certainly be mindful. Annual evaluation, any type of abnormal uterine bleeding would definitely need to be evaluated.
Wonderful. Thank you so much. Absolutely. We want to I can't tell you how much information I've learned tonight. I hope that those in attendance felt the same. We've recorded this seminar, so if you'd like to review it or you'd like the slides, again, we've got those. Thank you to our interpreters tonight. We really worked hard to make sure that they're being recorded tonight for our folks that need it. Amy, I know you had to come late, and I'm hoping this works out for you too, but a huge thank you, Ashley Smith. This was wonderful.
Well, thanks for having me. I'm welcome to come anytime. So you need anything, you just let me know.
We will. Please fill out the survey that you're going to see pop up on your screen when you leave. And thank you all for sharing this time with us. I appreciate it. Have a great night, everyone. Good night.